and welcome everybody. Do take your seats for this plenary session. Apologies for a little bit late starting. I can guarantee it'll be worth the wait. Thank you very much for coming along for this plenary session on the human touch in a digital world, where we're going to be considering how the core relationship between patient and practitioner is affected by digital technology that's already beginning to influence our healthcare. My name is Sue Saville. I was medical correspondent with ITV News in Britain for many years, and I'm delighted to be chairing this session this afternoon with our great group of speakers. The days of Doctor Knows Best are probably over now, perhaps, well, at least in the human form. Too many people, some doctors will say, are relying on Dr. Google to get some information and opinions before they go into their appointment. But we need to think, is this actually empowering patients, giving them information, or is it in some way detrimentally challenging the professionalism of the healthcare professional that they're going to visit? With so many apps and consumer wearables, we can all track our health and keep in touch with things. But again, is this empowering us in some way, or is it perhaps encouraging hypochondria, hysteria, and perhaps unnecessary medical appointments? Trust must surely be at the heart of the relationship between patient and their doctor or healthcare practitioner. But what do we mean by trust then when machine learning comes into it? In the UK, I've heard that around 2,000 people every year die on the roads from car accidents. And if you think about self-driving cars, if you had even just 2 of those coming in to the equation, would we allow that sort of technology to continue, or would that company go out of business? So where do we set the standards? Where are the bars when it comes to healthcare technology? We're certainly going to be talking about AI, but what is it? How do we define it? Is it artificial intelligence, with all the connotations that artificial is fake or Frankenstein or somehow rather emotive, like the words like genetically modified foods or nuclear medicine? Perhaps we should talk about augmented insights, somehow that complement with algorithms the professionalism of the doctors. And I hope that with the panel and our speakers here, we're going to be able to tease that one out a little bit more. So there are huge issues also we need to consider around ethics, around consent, about where data goes. Where does the patient end up in all of this? There are legislative, regulatory issues, and of course the cross-borders, and everybody here from across Europe will need to think about standardization so that patients can have that reassurance that somewhere there is still a human touch in the digital world. Now, we very much want you to be able to have your say. We'll be able to reach you with roaming microphones. There's also the Wisembly system, which means that you can get onto your digitools and you can talk to the amazing newsroom over here, who are going to be listening into any comments that you have, any questions you might want to raise. We also have Flores, who's our cartoonist. I love to feel that in a piece about digital tools, we've got a man there with his pen, drawing in the good old-fashioned way, and see what he captures from this afternoon. Before I introduce you to our speakers, it's a great honor to have with us the regional nominee for the European Office of the World Health Organization. Please join me in welcoming Dr. Hans Kluge. Over to Hans.
Thank you very much, Sue, and good afternoon, distinguished guests, ladies and gentlemen. First and foremost, I would like to thank my long-standing respected friend, the President of Gastein, Dr. Clemens Ode, for inviting me here to share with you my thoughts and the evolving vision on the future of digital health, which is a priority for myself, for WHO Europe, and globally. And let me straight away start with the 3 key messages in my speech. The first one is that WHO's work in advancing the field of digital health is anchored in the Sustainable Development Goals, in ensuring the delivery of safe and inclusive digital health services. Number 1. Number 2, I believe we are sleepwalking into a worsening digital divide, and more needs to be done to counteract this. And number 3, leveraging the digital technologies of the future in health requires a new model of governance and action. It is no secret that digital technologies are redefining our perspectives and raising our expectations of how the future of public health and health systems will operate and how and where healthcare will be delivered to the individual. As many of you know, one of the key promises of my recent campaign and what I heard time and again from the many key decision makers I met with is a need and a commitment to strengthen the digitalization of health systems in the 53 countries in the WHO European region. But beyond a promise, what do we really mean by this? I am sure you're as excited and likely as optimistic as I am about the digital innovations in health that we see emerging on the horizon, despite the fact that they at times raise questions and concerns and even challenge what we feel comfortable with in terms of our healthcare delivery and the use of our personal health data. The role that governments, civil society, academia and the private sector will have in bringing these emerging innovations into our health system is changing. In some cases, too fast, and in other cases, not fast enough. Regardless, I don't believe that a future of our health systems, as they become increasingly digitalized, is a fait accompli. But we do need to act now to make digital health services of the future safe, accessible, and affordable for all. Over the past 6 months, I have made it my personal objective to listen to as many health leaders and foreign affairs leaders and partners as possible in all 53 member states. And I learned a lot more than expected to. And I would like to share with you some of the multitude of challenges in reforming and maintaining the national health systems which the health leaders shared with me. In particularly, managing the increasing cost of healthcare and pharmaceuticals, adapting health services to changes in population demographics and aging, addressing concerns about the health workforce sustainability, particularly nurses, and meeting the growing patient demand for more personalized health services. These are just some of the issues the health leaders told me. And this comes on top of constantly being on the back foot in dealing with the media, the unions, and the private interests. All of these drivers, in turn, are raising broader societal concerns around affordability and sustainable financing for health, adequate and well-trained health workforce, the ability of health systems to continue to provide timely and quality care to citizens while preserving our European model of universal access to healthcare based on the values of equity and solidarity on which I will continue to stand very strong. While many countries are investing in digital solutions to solve some of these issues, we must take a step back and look wider than just technology itself. We need to critically ask the question as to whether we are actually applying technology in the right way to solve the right problems. Are we achieving health policy goals and addressing the social determinants that influence the ability to scale up digital solutions and ensure their reach to the poorest and most marginalized people in society? Or are we merely perpetuating an infatuation with costly gadgets in the blind hope that they will somehow address the issues we find most uncomfortable to discuss? Talking about the next upgrade in technology is easy. Talking about the person being downgraded or pushed into poverty in order to afford health services, digital or otherwise, is not. This is why the actions of the World Health Organization and partners in developing digital health in countries are anchored in the United Nations Sustainable Development Goals, universal health coverage, and the WHO triple billion target. The benefits of taking this approach are clear. It ensures equitable access to services, improves population health and life expectancy, reduces poverty, drives economic growth, like the Finnish EU presidency with the support of the European Observatory is showing us. It improves gender equality and increases health security. The implementation of digital health must therefore take as its point of departure a commitment to ensure no one is left behind by developing ethical and morally responsible policies and governance frameworks, accessible and affordable solutions, and digital public goods for all. This is the basis upon which the WHO Global Digital Health Strategy, currently under finalization after several rounds of consultation with the public and member states, is founded. The strategy is expected to be adopted at the coming World Health Assembly in 2020. Ironically, applying digital technologies in health has the potential to both bring us together by bridging geographical divides, but also to pull us apart. For example, in removing the need for the human touch and human interaction. Looking at the so-called digital divide in health implies addressing a different sense of pulling apart. That is, a separation on the basis of inequalities in accessing digital health services. My sense is that when I look at the increasing influence of tech giants in health and how unprepared we are in Europe for the paradigm shift that their presence will undoubtedly bring, that we are sleepwalking into a worsening digital divide in Europe, and much more needs to be done to counteract this. Marginalization of individuals or population groups on the basis of their inability to afford, access or use digital health services is simply unacceptable, and it will lead to a significant social inequality and loss of economic potential. Strong arming governments into expensive procurement engagements and procurements, the cost of which will pass on to individuals, achieves the same end result. So let's be frank about this. We all want health services provided by digital means that are safe and empower us individually with convenience, information and choice. But in working towards this model of health service delivery, with very little say in how these services are designed and ignoring the commercial motives that drive them, are we silently complicit in denying a segment of the population the right to future access of the same benefits and quality of care? We cannot afford to have people that cannot afford health services provided digitally. I would like to put a challenge to all of us in tackling this digital divide, and I know it won't be easy. But can we imagine a future where we evaluate and invest in digital health solutions not upon the basis of the financial return on investment, but on the social return on investment? How could we do that? What would it look like? What factors would we include? I honestly, as of today, do not have the answer, but I'm sure that collectively we do. We need to be able to better quantify the digital divide in practical terms that decision makers can use, and once we do, I am certain that concrete solutions to address it will emerge. Another key observation from my discussions with health decision makers is that our ability to effectively leverage the digital technologies of the future in health requires a new model of governance and action by member states, one that is built for a 21st century service delivery model, and for health leaders to acknowledge their leadership role in advancing the digital health landscape. I again want to speak openly here. Our technical resources have discussed until they are blue in the face about the needs for interoperability of health data. Yet, I rarely see the effective governance of the standards or of health data, or the political leadership that is going to bring us here. At the same time, we are lacking an agreed approach for gathering evidence as to the safety and efficacy of digital health, including, most notably, for artificial intelligence. I am aware that this has been mentioned by others on many occasions in the past, and several attempts have been made to develop new evaluation methodologies and certification models for digital solutions that take into account the dynamic nature of the technology development process. But we as yet have no agreement, and countries lack a significant body of knowledge as to how to tackle those issues, which is holding them back. The WHO European Roadmap on the digitalization of health systems, which many of you are aware and have contributed to in different ways, and which I will continue to personally champion, will attempt to bring together the basic building blocks of digital health systems with a particular emphasis on equity and governance, trying to make clear what good governance of digital health looks like. Finally, I would like to emphasize, as I have done in the past, the need for meaningful partnerships for digital health, engaging civil society, patients, public and private entities. Those who met me on my campaign have been hearing time and again that for me, partnership is not a matter of goodwill. Partnership is an ethical duty. This is an absolute must for all European population to be able to benefit from effective, equitable and timely care delivered by well-functioning and accessible health services. We still have some work to do to coalesce the different interests of digital health stakeholders, but we all stand to benefit from more effective partnerships that are focused on delivering an agreed agenda for action. I encourage us together to accelerate action in working towards the development of digital services that are both safe and inclusive, and that seek to deliver on the promise of more accessible and timely health services and information. At the same time, we must make conscious and evidence-based choices as to where the digitalization of health makes most sense and where it does not make sense. And this will help us to preserve the human touch in healthcare when and where it is needed. Social justice has been the foundation of my entire career, and I strongly believe that no technology will ever replace the human touch to leave no one behind. Thank you.
Dr. Kluge, thank you very much indeed for those opening remarks, and you've thrown up certainly some challenges there, not only for those speakers we're going to be talking shortly with, but also for everyone in the room and indeed right across Europe. Thank you for that. Before the speakers join me on the stage here, we're going to take a couple of minutes to catch up on something very digital, the hackathon. You may be aware this has been going on throughout the forum. We'll have a little update now and see how things are going.
At DIT Health, we truly believe that innovation in healthcare can be driven perfectly by entrepreneurial spirit and entrepreneurial mindset. And we want to engage those that have great ideas to turn their ideas into real products themselves. And a hackathon could be a first step for that.
As parents of 4 children that went through this experience of having healthy children and were afraid of vaccinating them, we wanted to explain how a hesitant parent thinks, because this is important to understand the hesitancy, because then you can reply, you can offer solutions, you can invite the hesitant one, will rethink it, and then at the end vaccine his children.
I think the hackathon is a good idea. There is only one concern, that it is temporary. So many times when I see a hackathon, I see the good and nice ideas, And if there was a little process support to those ideas, all of them could grow. I think we should complement hackathons and long-term process support, and then it's perfect.
I was impressed by the fact that it was an open, multidisciplinary and interdisciplinary spirit. So that's really nice to see that, and I see that it's really changed, and this is a disruptive innovation that our young people are prepared to listen. So I think this is a very positive sign of the evolution of our young people.
We do not only want to award the real good innovators, we also want them to turn their idea into a concrete startup, into a concrete business. And that's what EIT Health is all about. We want to foster entrepreneurship in healthcare.
Excellent. So there we go, and the hackathon goes on. Please would our speakers now come and join me up on the stage, and we will get going with our discussions, certainly picking up on some of the points that Dr. Kluger raised there. I'm going to ask each of our speakers to introduce themselves, but very briefly, we have Professor Ran Balaser from Israel, Indra Joshua, Head of Digital Health at NHSX from the UK, Anna Stavdul, who comes to us from Norway as a doctor, Sarunas Narbutas, Chairman of Youth Cancer Group, and Marco Marcella from the European Commission, but that's very brief. Individually, would you please introduce yourselves, and on the issue of the human touch in a digital world, very briefly, Ran.
Hi, everyone. So my name is Ran Balaser. I'm a public health physician by training, and I come from Israel, where I serve as Chief Innovation Officer for Clalit, which is the healthcare payer provider for half of the Israeli population. I'm also the chair of the WHO Collaborating Center on Non-Communicable Disease Research Prevention and Control, the Clalit Research Institute, and I serve as a professor at the University on Public Health. Just a few words. I think what we'll try to cover today is to alleviate some of the fears that are associated with, our new AI overlords coming to take all our positions and replace us. So I think that we will discuss today why that couldn't be farther than the truth, and that actually AI and digitalization could restore the human aspect of the medical profession, as well as all of the allied health professions as well. So I hope we will touch upon that today.
Thank you. Sarunas.
Hello, Šarūnas Narbutas from Lithuania. I'm a cancer patient living with leukemia for 13 years. I'm a lawyer. I was advising the president of Lithuania, and at international level, I'm active in the CML Advocates Network, which is a global organization for my disease, where I'm chairing it. At European level, I'm here for the Youth Cancer Europe. And at Lithuanian level, I head the umbrella of Cancer Patient Organization, which is the biggest NGO in the health field. My take on this would be one example. In this July in Budapest, in the European Youth Center, we hosted an event for Youth Cancer Europe, where we invited leadership of young cancer survivors. Young is 18 to 39. And all of them were either the best there is in their country who are advocating for their cancer patients' rights, or they are influencers in social media. So just in that room with 80 people, we had an outreach to 500,000 young cancer patients in Europe. That's a lot. And we posed a number of questions in a Slido manner. And we asked them, the people who are tweeting, the people who are in the Instagrams, and we are just the background noise being here, human touch, we are being here while they are on their phones. We asked them, whether do you prefer digital or human interaction? 8 out of 10 said we prefer human interaction. And I think that's a big message, because this is a digital generation, the ones that we think we are living in digital, and we still want to be heard and have this face-to-face interactions.
Thank you.
Hi everyone, my name's Indra. I'm also a doctor by trade. I'm an emergency medic. However, I don't practice currently. Currently I work in an organisation called NHSX, which is a joint unit between NHS England, the Central Commissioner in England, in the UK, and the Department of Health. I have so much to say on this topic, and I know some of you in the audience may have heard my wonderful dulcet tones in other forums this morning or yesterday. One of the things I would say, I would totally agree with Hans, is you do need to create frameworks and standards in this place. You need an agreement on that, not just across policy, but across industry and people as well. I've got some great examples which I'll share with you as we go along. But the only thing I would do is echo what you have said. There was a great study that was done by UCLA where they used apps for children who had mental health problems. And these were children who were put into foster care. And they were saying, you know, how can they help you with your condition? And at the end of the study, they went and asked the children again. They said, what's the best thing out of all of this? Which was the best tool? And overwhelmingly, the children said the best point of the day was when the social worker knocked on the door and would take me out for an ice cream.
Wow. Thank you.
So I'm Anna. I'm a family doctor in Oslo, Norway. I have been providing human touch for 30 years as a family doctor in the same area in my city. I'm also a university teacher and a trainer for family medicine specialist candidates. Currently, I am the president-elect of the World Organization of Family Doctors, WONCA. We represent more than 500,000 family doctors worldwide working in education, research, quality and patient safety. I also just stepped down as the European president, so I've been in this game for some years. Well, I have 4 aspects I think is interesting to discuss from the family doctor's perspective. First one is adapting to digital health. How can we do that without losing sight of our core values, which is personal, continuous, comprehensive care? The second one is how can we make sure that digital health will increase equity in health and not the opposite? Third, how can we ensure that digital health will decrease overdiagnosis and not the opposite? And the fourth thing is how to ensure partnership, as Hans mentioned, and involve patients and health professionals in creation, implementation, and not least evaluation of digital health tools.
Anna, thank you.
So, my name is Marco. I work for the European Commission in the department DigiConnect, that is supervising, let's say, policy and research and innovation action for the digital economy and the digital society. We do also support research and innovation activities, and I am specifically working in a team that deals with e-health, with well-beings and agings. And we do have a portfolio of actions that cover, let's say, policy activities, for instance, on data, and research and innovations actions. Now, we work together very closely with our colleagues in DG Santé and in DG Research and others in the Commission to deliver on the strategy for the digitizations of health and care. And it is a strategy that is anchored on people's access to data, on new generations of new data, for instance on genomics, supporting linking and interlinking of databases, and then putting this data into use to empower the people to take care of their health and also other health sector professionals in clinical decisions making. And my take into the digital touch or the human touch on digital evolution is that the technology per se, or developing technology for the sake of the technology development, doesn't take us very far. And the experience in developing technologies for assistive technologies people with disabilities or inclusive technologies realizes how important it is to take into account that eventually that technology will be used by humans, which means that at the outset, from the design of that technology, the human is at the center of development. Now, there are 3 aspects that we'll be sure covering today that are making that technological evolution trustworthy. First, that it is a lawful development. Second, that is ethical development, that is ethically sound. And third, that is robust per se. So eventually, this human touch is all about, well, the the rights of the individuals and respecting the rights of individuals.
Thank you all for introducing yourselves and giving us an outline of where you come from on this. I think, Ran, you started out as the most optimistic and positive, so I'm going to start with you. I understand that in Israel, the technologies have been put into place very quickly and very extensively. There are great issues, obviously, around cybersecurity and so on, but you feel that your country has got ahead with this. Why? Why is Israel so far ahead on this issue?
I can think of several reasons for that. One is because we started earlier. We have digitized all of our electronic health records back in the 90s. So we have about 20 years of electronic medical records, both inpatient and outpatient. The second thing that we put in place fairly early afterwards was interoperability systems that allowed different parts of the silos of the healthcare system to interconnect. And so for quite a few years now, if you enter any ER, you are able to see all of the information from the community setting and vice versa. So this potential continuity of care has shown value to the public fairly early on, so they can support continuously. And the third point that I will mention is that Israel is sometimes looked at as a startup nation, where people are very bold in their attempt to innovate and to take risks. And this risk-taking behavior is proving very beneficial when we have a lot of basically both engineers and healthcare professionals willing to take part in this game of innovation in the healthcare arena and using data in a smart way to support the patient needs. So as we see more and more benefits from it, more and more players come into this game.
Thank you. What about for other healthcare systems? Obviously, across Europe, there's a variety of systems in place. Indra was saying with the NHS-X, is that something that could look to, say, Israel for best practice, for adopting that continuity of care, for getting systems to talk to each other? How's that looking in the UK?
I mean, when we talk about digitization, I think there's two things you can talk about. I'm just going to pause. I'm conscious there's an echo. Can people still hear us, and is that okay? Just raise your hands if it's good. Perfect. Okay.
They're still with us.
Sorry.
Well done.
So there's two things. There's digitizing systems, so there's implementing EMRs, there's actually doing things in a digital way. And then there's what we would call digital therapeutics. So treating people or having a therapy that is actually in a digital format or a technical format versus the traditional face-to-face. In the UK, we've really tried to push on ahead in this and create some standards. So you need clear standards, and what I mean by standards are things like SNOMED CT, which is a data standard, LOINC, transformation of data interoperability, but also you need APIs. Hands up those of you, if I say an API, like, yeah, totally got you. Okay, great, man at the back, well done. And gentleman here.
Please explain.
So an API is basically a lock and a key, in a very simple sense. You know, if you're going to create an infrastructure, it needs to talk to another infrastructure, and it needs to have a key to put into the lock so that they can talk to one another. So in the digital world, we talk about APIs, and that is key. APIs are about an interface that allows information to be exchanged in a standard format. And so we know that this is really important, and we've really pushed on ahead with some of that, and we have some national products, for example, like NHS.UK, which used to be called NHS Choices. And all it is about trusted content. So if you've got a cold, you want to like, oh, I don't know what to do with my cold, you put it in and hopefully it comes up first on Google. We work quite hard with them to try and pop up our content. And the idea is that you get trusted content. We talked about trust earlier, so that you know, okay, I need to give my child, I don't know, 5 milligrams of paracetamol because this is the right dose. And how do you then exchange that information across any platform? So we have around 2,000 companies who actually take that content because we have published an open API.
Thank you. But what about across boundaries? Well, Anna, you want to come in there, but I'm also keen to hear from Marco across the European perspective. Anna, what's your take on that?
Well, speaking about continuity of care and linking that to the electronic record shared by all of us, I think we shall be a little bit careful because continuity, that is one sort of continuity of care. I think we already referred to, and the two speakers here referred to the human touch with stories and own experiences. The personal continuity is something else. And that is also because about the silent knowledge you have about the patient. We also have an electronic record in Norway now, which can be shared in the whole healthcare system. I know that there are things I would never, ever write in that record. And my patients also ask, they point to my computer and say, is everything in there? No, it's not. It's here.
You don't trust the
So
system?
continuity of care should be operationalized when we speak of different things. This is a technical continuity of care,
Yes.
and only a small part of it.
Thank you. Marco, what then about continuity across borders? Indra was talking about standardization there. How can we get standards across Europe that are going to be fair, even, equitable?
Well, continuity of care is one of the, as I would say, use case for an important project that the member states and the European Commissions are now endeavoring to deliver. And that is the health digital service infrastructure. So if I use these acronyms, but it's important if you intend one day to Google them. And what is the point there? So making sure that there is health data that can travel across the member states, some specific health data, in this case, patient summary, so a small portions of the health record, and e-prescriptions in a way that is smoothly understood across borders. Now, this is an endeavor, it's a voluntary endeavor of member states, and the European Commission is supporting the tunnel, if you want, in joining the sources of this information. So how do we do that? Well, the starting point of this exercise, it is the incredible fragmentation of electronic health record data. Mm-hmm. So the fact that you have different standards, some are proprietary standards. So the key effort there was in making sure that at least we agree on one mechanism that technically enables us to exchange data across borders. But that is not sufficient, because then you have to add on the top of technical layers whether we understand the same thing in the same way. So you have this semantic component that is important. And in addition to that, you also have the legal interoperability, and then the organizational interoperability. I think that this is an important effort, and at the moment, I mean, it went live, this technological solutions in January, and it went live to exchange e-prescriptions, and 2 member states started, so Finland and Estonia, and today we already have around 5,000 e-prescriptions exchanged between Estonia and Finland. Now, what is the key there is that we are able to transfer data in a way that we understand each other, also for continuity of care. So in April, the Commission put forward a recommendation to the member states, establishing a series of standards and specifications, not, invented for the sake of invention, but based on what is going on already. And those standards, if used to exchange data, would guarantee that at least the level of, or the barriers to exchange data would be lower. And the member states took up into the health network, that is a voluntary effort created by the cross-border directive, took up this into guidelines to make sure, for instance, that in procurements we use a set of standards that can help us in making sure that this information is interoperable. Now, interoperability is key if we want to have a data-driven digital transformations of health and care.
Thank you. Thank you. Sarunas, from the patient's perspective, I understand that you have your own cancer-specific registries. Is that something you prefer to rely on, or are you comfortable to put the data into wider integrated systems?
Okay, so I'll explain something about it. In Lithuania, we have a hospital sitting on piles of data, siloed. We have an electronical national e-health system, but data there is not very specific. We are the patients on the ground, and we want to say what type of data on cancer does our government have, is sitting in our public hospitals, is going through our taxpayers' money. The answer is we do not get access to it. And that is wrong, and we are strong as an NGO, and this is why we are creating our own registry, patient-led registry. We are not saying we will have 100% of cancer patients with specific diagnosis in there, but at least we will be able to come up not with anecdotal stories of what patients are experiencing, but with the cohorts that could then guide decision-making. And I think this should be encouraged and done by the government. They are not acting against us, but they are not encouraging this approach. So we are pushing for open data. We are pushing it it at national level and international level. If the data is sitting where it should be there for the society, not just to guide the policy making for the public officials, not just for the healthcare professionals or academics, but to the patients and to the society and to the media when we're asking these questions. And it is a terrible reality when we do not know exactly how many cancer patients are there in Lithuania. We know how many die. That fact we cannot fake, right? But we do not know how many of them have been diagnosed and which exactly stage, and that is just the tip of an iceberg. What I am going through is like we actually want to know what our patients experience outside of a healthcare system. We can believe and assume that they will get, that part assessed when they go to the medical doctor, when the electronic medical record is created, but they are wearing gadgets. They are having all of that enormous terabytes of data sitting on other devices, which is not channeling anyhow to the healthcare system, which is not guiding any decision making in there. And with that, we want to help patient not to get to the doctor and speak with him. Of course we want to do that, but we want to change his lifestyle. So to know what to eat, what to exercise, what is good way to improve their health literacy, and to explain this to your fellow peer, who could be a patient, who could be a caregiver. And currently we're not doing that because we're sitting on these silos of data. So that is what, again, we are trying at Lithuanian level to create this patient-led registries for the app, which was created by the patients, which is an open API. And the question which we are posing to the government, why don't you make your e-health system open API so we can get into the same app in the data that is actually belonging to the patient, so we get the ownership to that data. We can take it abroad, we can channel the information through other gadgets, and we're working on it with no support through EU or the government, but I think it's another path. I'm not saying it's the only path, but clearly that was an unmet need that we are tackling.
And thank you. You raise a very interesting point there about ownership of data, which is going to be fundamental in all of this. Who owns the data? Is it the patient whose data has gone in? Is it the systems that have ploughed money into setting this up? Who owns data? Indra, you're shaking your head. And Anna, I think, would like to come in too.
What do you mean with data? I mean, who owns me? Who owns my health? Of course, it's the patient, it's the individual who owns the knowledge about him or herself. But I think we're discussing a very important thing here, and we easily go astray because we're speaking about language, about labels, and we think that labels can, explain everything. I'm sure you agree with me with your diagnosis. You have that label, but you're not necessarily similar to your fellow patient with the same label. And that is where we get back to the personal mosaic, so to say, the jigsaw puzzle, which is one in each of us. Of course, the individual owns the data, but what is data? Is that what we as professionals can label, or is it the story? Is it the narrative of the person? And I tend to, as you understand, to say it's the last
Interesting point. Thank you. Ran, you wanted to comment on that?
Well, we cannot overstate the importance of the personal narrative and all of the information that the physician, only your personal physician, knows about you. While we cannot overstate the importance of the narrative and the information that only the physician knows about their own patient, there is massive value in allowing the mundane labeling of data that is available on a massive scale. And the reason for that is that we cannot truly provide population health without having population level data. And if we want to move away from the reactive therapeutic paradigm that we have been using for so many years, quite successfully on with a single physician, single patient level. But on a population level, we need to move away from that towards something that is much more proactive, much more predictive in approach, and allows us to do truly preventive medicine on a population scale. To be able to do this on massive scales, we do need a lot of population level data, and to use all of the new types of AI and other machine learning approaches in order to provide us with inferences. In Israel, for instance, as an example, we identify patients that will have kidney disease 5 years before they have their first symptoms through a risk score that is AI-driven, we approach those patients proactively through the system and alert them that perhaps they should change something in their lifestyle. We do the same every winter when we want to allocate our influenza vaccines, and we identify the patients at the highest risk using those predictive scores. And I can give examples from cancer, from deterioration among elderly, and many other examples that could be given. If we want to be able to do this on scale, we really have to have population-level data while keeping, the privacy and all the security and all of the other caveats. But remember, we always look at the risk of doing something. The risk of not doing anything is just as great or even bigger. And we always have to take that there are two sides to this equation.
Thank you. Indra, you'd like to come in there?
Yeah, just really briefly, when I hear the word data ownership, it bothers me. And we have to move the paradigm. It's no longer ownership, it's the flow of data. So who's controlling the data? Who's processing the data? What's the impact on that data? So that's my short, brief point.
Thank you for that. I very much want to hear from anybody on the floor who's got points they'd like to make, either to raise your hands and we will get microphones to you, to put your points to this distinguished panel. You can also access through Twitter and through the Y-Assembly. I'd like to throw now to our newsroom who've been sitting there listening and taking notes. Newsroom, is there anything that you'd like to highlight that's come up that you could show us already on the screens?
Yeah, I mean, true. Can you hear me? Yeah. True to our age, there's been quite a polarized response, centering around 3 themes. You can see a polarized one at the top there. The centering around 3 themes, and the first one is, must AI be purely technical, or can it also deliver a human touch? And there's people on both sides. Secondly, is technology innovating in a blind manner at the expense of inequality? And does it need to be directed towards our public health or societal goals, or does it not? And finally, data has a mixed record in actually delivering benefits to patients. And again, people are very polarized on them. We haven't had that many disruptive tweets, though, so we're keen to have some more disruptive tweets.
Keep tweeting. Anyone from the floor at the moment like to make a question? Would you be kind enough to introduce yourself, please?
Hello, my name is Christian Franz. I'm working for a firm called CPC Analytics. And one of the things that I wanted to bring up is there is so much happening on unpacking algorithms. Today and also yesterday I heard barely anything of that. So we talk a lot about how beautiful AI is in terms of image recognition. But what about understanding what the algorithm sees? And I think the health community needs to engage more and more in this. Thanks.
Thank you. Who'd like to take that up? What do the algorithms actually mean, Indra?
So that's a question that has now been raised, and I talked about it a little bit earlier. It's the explicability. So when you're talking about in an ethics sense, how do you explain something? And we should be really clear that just because you can explain an algorithm doesn't necessarily mean that the interpretability is good. So there are 2 aspects to when you're talking about data and algorithms. We've worked across lots of sectors, and I know the WHO have a group as well who've partnered with the ITU to look at some of these bigger, deeper questions about how do you actually explain an algorithm. And we've just done something really brief, and we've tried to give a toolkit to people to say, can you work through not only where your data is coming from, the bias and the proportionality of that data that built the algorithm, but the suspected impact that that thing has, which in turn is a toolkit to help us as policymakers understand the explicability. What we haven't quite captured yet is the interpretability then, because a model can work, for example, in Israel perfectly, but if I'm going to then deploy that model, say in London or here in Gastein, do I know it will also have the same output?
Thank you. Marco, you'd like to pick up on that?
Yeah, I think these aspects are central to the development of AI in healthcare. And I wanted to mention the work on the so-called trustworthy AI. So in Europe, we are having an effort to create capacity in developing AI application, to provide technological solutions, to develop the researchers, to develop the skills, but at the same time, we are putting the trustworthy element at the same level of the development. And the high-level group on the artificial intelligence came up with a series of principles, ethic principles, in which explainability is part of the equation, that actually defines how or sets the baselines for a trustworthy development of AI application. There is a pilot phase ongoing. There is a pilot phase for sectors to check the applicability of these principles in reality. And one of these aspects would be, one of these sectors will be health and care sectors. So we hope by the end of the year to get feedback on the applications of those principles for trustworthy development of AI in that sector, which may take forward the discussions and the narratives on those aspects next year.
Thank you. Rani, you wanted to come back on that?
Just a quick comment. I think it was Kathy O'Neill that said that algorithms are not impartial judges. They're just opinions embedded in code. And I think that's a beautiful saying. It makes us all think. There's a problem with some of these algorithms when they're based on an unjust reality. And they take that into account, and then they just make it continuously go on. But there are also some mechanical problems with creating some of these models because they discriminate against minority groups per definition through statistics. One of the things we've done at Clalit is create like a tweak, a mathematical tweak that works on the algorithm after it's done, and it fixes some of those imbalances between the smaller groups and the larger groups that are within that population, and helps to reduce some of the inequality that is embedded in some of these machine learning algorithms.
That's very helpful, and it draws on the point that Dr. Hans Kluge made earlier about the risk of a digital divide and sleepwalking into that, and whether actually digital tools will enhance equality in healthcare or actually create further problems. Anna, what's your take?
Well, I'm just reflecting. I've fallen off now in the last part of the discussion, and I think that illustrates something. Representing the workforce and back to the human touch. Mm-hmm. Because now I thought we were up in the air. I'll make 2 points. I think on behalf of my own profession, we have been a little bit too lazy to understand the technology, the basis for technology. We know much more about what our houses are made of than what these tools we're using in practice. But that's self-reflection. But again, back to the impact of this for human beings. When we are using these algorithms, algorithms are not value-based. People's choices are value-based. That is the point of departure for me as a doctor when I meet my patients. And the first question is, what can I help you with today? What would you, more than anything else, want me to help you with now? And back to one of my introductory remarks, and again back to WHO, no one left behind. Mm-hmm. What I fear is that digital tools are at risk of being offered to people who cannot, like myself, judge the basis of it on a technological basis. You are told that this is good, whereas people who can pay, they will continue to pay for my time and my attention. This is just to bring the discussion back to the human touch, which we were here to discuss.
And at that point, let's get the human touch. Let's get the artist in. Flores, how are you getting on? Is there something you can show us as how you've captured the mood or discussion so far? It would be interesting to see where the human touch, the human hand, has come in on this. Are we able to connect? Let's have a look. Do you speak human? I love it. Are these going to be available later for sale, I hope? Gosh. Lovely. Any more? Oh, sleepwalking into the digital divide. Hans, you've got to put that up at home. That's a good one for you. a personal downgrade, inequality. Wow. The human touch. Well, these are excellent. Flores, thank you very much. Keep drawing, keep capturing the mood. And I think the points there that Anna raised about the values base, that had a murmur of acceptance and recognition in the newsroom, in the room here. And I think that was absolutely fundamental, going back to values that the doctor, that the healthcare practitioner is dealing with on a personal level with the human touch of the patient. Sarunas, what's your take on that? How can that relationship remain within the connection between the patient and the healthcare practitioner? Is it going to be lost with the top-down of the technology that's coming in from above?
I would not address it like globally, in terms of the technology. You need to look at that solution and what exactly that solution does, because you can have a telemedicine that helps and telemedicine that is just bureaucratic and no one wants to use. So you have a technology and the proper implementation is the key. And in that terms, how, from the patient perspective, I want for this to see helping, so that I would have more face time with my doctor. Whatever the solution can be to do that, be it telemedicine or being just, for me, uploading my concerns digitally to the doctor before the visit so he knows what to ask. It's not a matter of interface, it's what you try to achieve. So I feel from my personal experience and talking with other peers that often that they are in the office, they feel underpowered to ask what they really care, because they are being threatened about, like, I want to be a good patient, not causing too many troubles. So if I'm fine with that back pain for today, I will not mention it. And that is something I would mention if I would have an opportunity to do so, providing, comments and some platform that the doctor could see. But also, I'm actually more sympathetic towards healthcare professionals and the doctors and the nurses that, there is increasing load of the patient flow and increasing less time of a patient face-to-face interaction. And I pity doctors in Western countries. In Lithuania, we don't have so many nurses because we are not that much not less cheaper compared to doctors, so you're not being referred to nurses all the time. So we're still in the luxurious time of having a sit down with the doctors. But that's where you actually want to speak with a person on your issues. And some of those issues are not on your disease. It's about the lifestyle interventions. And the doctors do not feel qualified to talk about it. They do not have any digital solution to help tailor it. An example back to Lithuania. This year, they introduced for the doctors the drug-to-drug interaction service from the Sweden model that we're using. That's all fine. I asked, why can't patients use this? You get a patient in her, okay, let's say 70s, who are taking, 5 different medicines, and we do not know if they're interacting each other or no. And yet she's taking one, but then increasing the risk of the cardiac arrest with another, and she does not know that. And doctors are thinking when prescribing about checking it, but we're not giving it back to the patients to empower them to really know what you're doing. Then I'm asking, if the solution is developed on drug-to-drug interaction, why are you not developing something which is evidence-based on nutrition, with a particular disease, with a particular therapy, what you should take, not take, because then the patients refer to just general wisdom, and they do crazy things, and you cannot argue with a patient who is saying, I will only do this or that, because that becomes a temple of belief. And you need some guidance. And when we were yesterday addressing about health literacy, I think when we are approaching the topic from this point, we need to look into what type of information would we want to get from the patient side, from the healthcare professional side, from the government side to solve the issue and not how to do it. First, as you said, we need to learn to ask the right questions. So what type of advice I need to get, and then you look into the solution. Because digital as such is not an answer.
And if I may be a bit disruptive in accordance with the theme of the forum, the points you raised there about the very design of the questions, if the patient is somehow designed out of the system because the relevant questions, the background, the context is lost, we perhaps should ask those who design these systems, some big companies, some names might come to mind, who design these systems that then become rather universal, and as Ranad said, they're not necessarily relevant to every country and every context. Is the patient somehow getting designed out? And I think, Anna, you wanted to come back on this.
I think you're pointing at something very important in the start of your last comment. Because what we want is that digital tools can free time so we can concentrate on the face-to-face contact with the patients. But unfortunately, that is not what is happening if you look at what health professionals are reporting. And in my group of family doctors, in some countries, the time they spend with patients face-to-face is as little as 25% of their working time. So it goes, I'm sad to say that, but in the wrong direction. And if you have workforce suffering from burnout, because they turn into technicians and sitting reporting and with their screen, well, you need healthy healthcare professionals as well. And yeah.
Indeed, indeed. Mark, I think we'll just come in and then run.
I want to stress the importance of having the human touch, even when you develop the new gadget and the innovation. This is not just developed by the coders or the developers. If you take, for instance, research and innovations actions, we always require that there is a balanced approach which reports and takes into on board the visions of everybody. The patients, the doctors, they have to use it for that particular technology. Where I see the issue here is that even though we create an interesting, innovative solutions, it is very complex to get it from the good idea to mainstream adoption. And that is something on which we also have a role to play. It's a partnership approach where we need to invest together to make sure that when you have that bright idea that does take into account the concerns or the views of the citizens, and at some stage it is deployed for the benefits of the patients for their outcomes.
Thank you. Ron.
I think one of the promises, truly, as you alluded to, is to take away the role of the physician as a technician physician that spends his time doing repetitive tasks that computerized systems can do better than him, quicker than him, and leave him the time to have the human touch that is needed. We have to remember that digitization could be a part of the solution, but could it worsen the problem significantly? And the classic examples is what we call sensoritis. You know, that people are starting. Sensoritis is just a funny term to allude to the fact that people are using more and more sensors that are creating more and more daily data, and then they come to the physician's table and they just put, additional loads of data and tell him, now figure it out. And that is not helpful, not for the physician. The last thing they need is more data on the table, and it's not helpful for the patients. And if we are not, as a community, able to control this, we will see an epidemic of overdiagnosis and over-treatment that will happen in the next 5 years that would put all of the current problems of overdiagnosis and over-treatment under shadow. This will be costly. This might actually drive the whole system downwards. So if we let all of the commercial companies lead the way and run the show and provide more and more sensors and more seemingly helpful solutions that are not solutions to anything at all, we will lose the fight. We, as the medical community, should be the ones helping our patients make smart decisions and not being, walking after the wrong direction. And right now, it is true. It seems like we're heading in the wrong direction.
Gosh, thank you. Indra, are we heading in the wrong direction?
Can I just, there's a question here.
Thank you. Yes, let's, lady at the front here. If you'd be kind enough to say who you are. There's a microphone.
Beate Wimmer-Buchinger, I come from Vienna, and I'm a professor of health and clinical psychology. So I like very much what you said, and I think that we struggled so long and do have now so many evidence of the factors of personality and emotions. And this is a thing I think we had to keep in mind. And of course, what you said, it can be, and we do know, that hysterical reactions or psychosomatic reactions then maybe will be forced by some dangers I cannot explain by myself. So we have to be aware of emotions. I think very well we have to go back to the personal interaction, what's going there and what's happening and how is understood what's going on. If I wear wearables and I have some data on my watch, and what does it make to me? So I think we have also to take in mind the psychological part of it. Thank you.
Thank you for that contribution. Indra, do you want to pick up on that?
I'm just going to say really briefly, I agree. Of course, we need to bring in the psychological part. I just felt, I don't know if others in the room, I mean, I'm finding it really difficult to sit still for the long hour and a half that we're here. So I'm just going to take a little thing and try and pep it up a bit. So can everybody stand up for me? Everybody, come on, you guys too. Your bum must be numb as well. My bum certainly is. We're talking about the human touch. High fives, fist pumps. If you really love each other, give each other a kiss. Yeah. Great. Yeah. Jiggle wiggle. Come on. Brilliant. Okay. Brilliant. Now we can all sit down. I think a lot of us here have seen some deep vein thromboses in our time, and a good TED talk is only 18 minutes long. But just to bring it up a bit, you know, I think there's a bit of doom and gloom, and when it comes to digital, you can actually do some really fun and really cool things. So I'm just going to give a couple of examples where I think it's brilliant, you know, and it has added to the human touch. So, for example, medical education. Hands up those of you who remember leaning over a cadaver. Do you remember a dead body? And you're like, oh my God, I can't actually see the brachial plexus. But you're like, no, you need to know it because actually you're going to operate on it. Some great tools out there. For example, touch surgery. It's a wonderful app. It uses a bit of VR, but it allows you to navigate the human body. So it's not the traditional sense that we're thinking about digital, but it's a great digital adjunct in medical education. Now, you can use exactly the same thing when you're doing a consultation. So you can use 3D imaging, and Microsoft have this brilliant thing called the HoloLens, which you can actually navigate where you're going to do your operation. And they use it a lot in children's surgery. So hands up any cardiac surgeons here, pediatric cardiac surgeons. None. Brilliant. So I can say what I want. No. So in pediatric surgery, you can imagine tiny, tiny, tiny heart, really difficult to navigate when you've got a flat 2D or 3D screen. But if you put that into like a 4-dimensional picture, you can really do some good stuff. So think about digitization in a slightly different way. I talked earlier about using AI, machine learning, to predict traffic lights to enable ambulances to go faster when they've got somebody going wrong. Another great thing we've seen is the use of ultrasound tools. At the moment, you know, you go into a hospital, you get a scan done, not really sure, is that fluid, is that not fluid, is that a heart, is it not a heart? You know, the machine can actually help augment some of those images and interpret them for you. So if you're not a skilled ultrasound professional, that can help you. And the great thing about that, where it adds to the human touch, is you can put it out in the community. So we've put it out in paramedics. So when they're at the roadside with somebody who is critically ill, it's not about, oh my God, whisk them and take them to hospital. Whack it on. Do it right there. So there's some really great things out there in digital that we might not always think about because we do sometimes get a bit hung up on things. And what I just wanted to say is there's some fantastic things. And patients are hacking their devices. I don't know if you've ever hacked one of yours, but I've seen patients who've come in with diabetes products and they've hacked them and they've actually made them better and worked for them. And they're sharing that stuff. So I think there's a wide range of stuff happening out there that is quite cool and whizzy.
Thank you for that upbeat note. Sarunas, as a patient.
Yeah, I wanted to reflect on that. We have a question here as well, but that was some examples of a high tech. I will refer to something which we are using and that's not so high tech. Text messages, SMS. That's technology, but that is getting into the hands of every elderly patient who is able to read in that big fonts. So what we actually are doing is for the patients in our community, and we serve 12,000 cancer patients every month through our patient organization, that this is how they know about the developments in the health policy area. What's the next reform coming up? This is how we know whether there are free tickets to the cultural events that we give out, or whether there is new upcoming opportunities. And this is how they know that the new medicine is being reimbursed. Because if it's not for SMS, if we relate to the app, if we relate to email, they will know about it a year later. So it's not about having the new high tech out there. It's all great, and I'm all in favor for that. But it's also about reaching out to these communities. There are different ways of making technology work, but some of the technology we all have been using before there was social media, and we were so happy with it. We should revisit because it's cheap. It's widespread. It's not something super fancy, but it's very efficient.
Thank you. I think it was a question, gentleman here, if we could get a microphone across.
Yes, I will stand up. Alan Moren from Epiconcept. We already talked in another session this morning. Hi, Ren, long time no see. What you just did You were convincing. People stood up. I didn't. Let's keep that in mind. If we go back to big data, how much are we sure that we are not shifting the responsibility of health from the patient, being able to say yes or no, I want to behave? When you see the insurance company, Kaiser Permanente in the US, putting a tremendous pressure on their clients to change their behavior. So what is public health? Is it to us to give the information to the patient so that the patient decides, or is it to us to harass the patient, force the patient to change its behavior? So I think there is a little bit of that in the game we played. Everybody stood up suddenly. Why? And this is used to convince people to force them, unfortunately.
Thank you. You've nudged or manipulated us, Indra. Who would like to take up the point, or should we just leave that hanging? Because I think that's a very good point made, because I think there were other hands before we... There's a lady there, if you'd be kind enough to introduce yourself and put your point.
Yes, hi, Tessa Richards from the BMJ. Surely can we agree on a basic principle that as we introduce these new digital technologies, that it should be, you know, the whole co-designed to answer Hans Kluge's question, when and where patients and their carers, they have to be at the table when those decisions are made. And surely we also need metrics. We've been hearing about freeing up doctors' time, more face-to-face time, empowering patients. Well, why don't we hold that as metrics? No new digital technology perhaps should be introduced, or it should show us how it might empower patients, how it might reduce the burden of navigating fragmented health systems, how it might provide more face-to-face time with, you know, between clinicians and patients, and how it might reduce health inequity. Can't we dream up some kind of metrics by which we should judge the introduction of new technologies?
Thank you, that's a good point. I'd like to go to the newsroom briefly, because we're coming to the end of our session, and I want to see if there's any other responses from the newsroom, and also to see what wonders Flores has created. So, any other points that have come out, please?
It's spiraled into quite a negative pile-on against data. So we weren't able to be super impartial, and as you've seen on the screen, but yeah, other than that, there were no particular themes that came out.
Thank you. Flores, where have we got to on capturing the moment with the images that you've been creating for us there? Can we see the latest that you've brought up? Images, no, we have a digital divide here between what we want and what we're going to get. I'm going to, and I'm sure there are plenty more questions in the newsroom that, here we are, that would be great, let's see. Sensoritis. Lovely, that's one for you, Ran. Excellent. Well, you've all made so many interesting observations. Yes, we've dipped a little bit into the negative because we've looked at some of the challenges and some of the issues. But it is, as we've been saying, right back to what about the patient? I'd like to ask each of our speakers to very, very briefly, in just a sentence or so, give us a couple of take-home messages from this session and where they stand on seeing if we should have and if we will have the human touch still in the digital world. If we go along the line, Marco, would you a couple of take-home thoughts?
Well, probably the most important one is to continue along these directions of partnership and co-design and co-evolution of these solutions, taking into account the fact that it is the human that eventually will coexist and will help in working together with these machines.
Thank you. Anna, a few take-home thoughts.
Hippocrates. You know Hippocrates? He said something like, it's more important to know what patient has a disease than to know what disease the patient has. 30 years of practice has taught me that there is some truth in that. We need digital tools which also apply to primary care, because that is what we agree on, isn't it? That is the cornerstone of healthcare.
Thank you. Indra.
I would say be a seed. All of you, be you the regional director to a young Ashtaina, you are all seeds. And make sure you embed the values, the ethics, the principles that we all have in health. Do good, don't do harm. and apply that in a digital way, be it either for digitization or digitally being therapeutic?
Thank you.
I would want to encourage you, whenever you want to embark in new technology, to look beneath what is promised, to look beneath what various technologies, so there will be data, and data is the new gold. So it's not just with intention to create more data, but what is the problem you are trying to solve? If you could just start, will this mean we will have more time in our daily lives or in the healthcare practice as an end point? This is what you want to achieve. That's a good benchmarking. Currently, I see that those benchmarks are far off the line. They are how it will monetize, how many data points will there be, what's about interoperability. That is a process-driven KPIs. Look for the issue, the fundamental issue you want to change, so that we as patients would embark in those technologies with no convincing.
Thank you. Andrea.
So, Sir William Osler, he was one of the greatest physicians ever lived. He said, if it wasn't for the great variability between human beings, that medicine might as well be a science and not an art. While that is true, I think it is time to infuse some more science into this art, which will benefit both the human touch and the actual outcomes of the care that we get and provide.
Well, thank you all very much for those thoughts, and thank you all for coming along to attend this plenary session. I want to thank the newsroom for monitoring things, for Flores for his observations there. I hope we might have another chance to see those somewhere. There is going to be an opportunity to visit the Disruption Lounge, which is outside. You can see a lot of the things that are going on here, so do take the opportunity to go to see that. I think we had a sense throughout the session here that the human touch should not be lost in the digital world, that somehow digital tools should enhance the relationship with the healthcare practitioner and not replace it. And with that thought, I want to thank you all, and please join me in thanking our specialist speakers. Thank you all very much indeed. Thank you.